In session 1, we're going to hear evidence from people who are living with long COVID. And in session 2, we're going to have evidence from experts and organisations working with people living with long COVID. So let me introduce our first panel of witnesses. First is Emily Miller. Emily is a student in Brighton. She contracted COVID in October 2020 and has since been living with it. As well as struggling physically, she's also struggling financially. She's unable to obtain support from the Disabled Students Allowance as they do not recognise long COVID as a long-term illness because it's a new condition. Stephen Clay is 54. He's also struggling financially as a result of living with long COVID, and as well as experiencing severe fatigue, headaches, and lightheadedness. Long COVID has had a significant impact on him and his family. And we're going to be joined by Tim Hughes. I see that Tim has joined us now. Tim is 37 years old, and his long COVID has left him unable to work due to many symptoms, including breathlessness, fatigue, chest pains, constant ache in the throat, feet swelling, dizzy spells, brain fog, memory loss, and others, among other symptoms. And we're very grateful, particularly given the daily living issues that long COVID gives you, that you're joining us today. So let me ask the first question, then I'll throw it open to my colleagues on the APPG. Emily, Tim, and Stephen, can you give us a brief overview of your situation? When did you contract COVID, and how have things changed for you since then? And can we start with you, Stephen?
Yes. Can you hear me okay? Yes. I first contracted COVID late November 2020, and it came, we know the source, it came from my son's school. The whole family had COVID. It wasn't particularly pleasant for a number of weeks. None of us were hospitalised though. I've had what I would consider 3 major relapses, and the relapses come about when I do too much, basically. So, and the relapses, the last one was September to, and I'm just getting over it now, September to November, where the symptoms are far, far worse, and you're more or less eating, sleeping, and doing very little else. In between so I had 6 months where I didn't have a relapse, but in order not to have a relapse, I had to manage my life so that I cut out just about everything. I stopped driving. I've not worked. I can't do DIY or chores around the home. I can't do any gardening. Days out with the family just don't exist. Holidaying abroad is not an option. And I used to be quite active. 2 years ago, I built a summer house for the kids and the friends to spend time in at night time, and I built it from scratch. I just ordered various sizes of 5 metre lengths of timber, cut it all, erected it all, did the design myself. While I've had long COVID, believe it or not, I've found a bird box that I bought from B&Q last year, and I couldn't even attach that to a drain pipe first time. I had to give it a week and try again, because you just can't, you forget how to do certain things, and you just can't focus and plan the same that you used to. Say I've given up driving. I used to travel with work throughout the East and West Midlands, attending meetings. So I'd either drive there or I'd get the train, and I always made a point at the other end of walking from the railway station to wherever the meeting was for a bit of exercise. Can't do any of that now. I literally walk to the bottom of the drive, and that's as far as I can go. So it took a lot of getting my head round, but I bought a mobility scooter in September just to, if I'm not driving and I can't walk anywhere, just as much for mental health as physical issues, just to get out a little bit. but that said, I probably only use that once or twice a week. I think the last time I went on it was Monday last week, so that's 8 days ago. So it's quite a significant impact on me. There's quite a big impact on the family as well, because all those tasks that I can't do, other people are picking up. So it's mainly my partner that's doing the gardening. It's just not sustainable long term. A lot of it. Even the dog walking. I've tried walking the dog on a mobility scooter, and that's proved too much. It might be something I can build up to over time, but at the moment it's too much to do. And just thinking about the generations, I mean, my parents are 86 and 87, and they will catch a bus into town. And I don't know what they think when they see me on a mobility scooter. They live 2 miles away, and I can't even go 2 miles to see them on it. So the independence is completely gone. And then my son, he's in his final year at school. He's doing his GCSEs, and he's on the autistic spectrum. So I'll see him in the morning, and after a good night's sleep, that's when I'm probably at my best at the moment. It fluctuates, but I know he's struggling at school, and I want to help him. And I've bought all the revision guides and everything, but then I can't cope with complex issues. Just gives me a headache. So things like hobbies, I used to be quite interested in family history, but just 5 to 10 minutes researching that gives me a headache, and headaches can last for 3 days.
Yeah, thank you, Stephen. That's really comprehensive. Thank you. Let me ask our other two panelists the same question. Emily, could you tell us about when you contracted COVID and how things have changed for you since?
So I got COVID mid-October 2020. We'd just gone back to blended learning in university, so we were mixing again in person. There wasn't, a mask mandate in classes, so people weren't wearing masks. I used to be a super active person. I'd walk everywhere I could. I'm studying music business, so I used to go to shows, work at shows. During my gap year and my first year of university, I was working maybe 30-hour weeks. Now I don't really leave the house unless it's for a medical appointment. I have to attend university, so I have to attend 40% of my classes in person, which has been really, really difficult for me. By the end of it, I just feel drunk. I can't talk to people. I can't remember conversations that I've had or what I've sat taking notes on in that class. I don't have a social life. I don't see any of my friends other than, my housemate who I live with, and speaking to people on the phone. So my life has completely changed. So has my career trajectory. It's just, completely different.
Yes, thanks, Emily. And Tim, the same question. When did you contract COVID and how have things changed since?
Morning. I tested positive with the PCR test on the 23rd of October 2020. I was hospitalised for 10 days. Since I came out, I can only echo what the other two have said, really, in that I struggle to go out. I've now lost my job. It's broken some of the friendships that I had because people want me to do things that I can't do. But it's also affected my living arrangements because I've had to give up where I was living. So I've had to move in with my brother, where I'm currently half the time in a bed, half the time on the floor. Because obviously I've lost my job, I can't afford anything. I'm currently trying to find social housing, but there's nothing in my area. So again, echoing what as somebody else has said, it's had a massive effect on my independence. Obviously, depression, mental health, and all that sort of stuff as well. It's massive effect.
Thanks, Jim. And just a quick second part of that question that I asked. Could you tell us, have you seen any improvement in the situation, the symptoms over time, and what support have you had from your GP? I'll start with you, Tim, as we've just spoken.
I've had some improvement with a cough, because for 8 months I had a continuous cough where I could barely talk. However, that's probably the only thing that I have had improvement with. Support from the GPs, in a way, yes, I have. The GP has been really good. However, they referred me to a long COVID clinic in January this year. I had a phone call from them. I listed all my symptoms. A month later, I should add, one of the bits of advice I got from long COVID clinic was that if my nose is running, I need to blow it. And then a month later, I get a phone call from long COVID nurse again, who said to me, there's nothing more we can do for you. You're now being discharged. So a month after a phone call, I get discharged and I've got exactly the same symptoms. Since then, I'm under a respiratory specialist who's also referred me to cardiologist. I'm under a speech and language therapist who's been amazing, really supportive, but she's recommending that I get a referral for ENT because they're not sure whether I've done damage to my vocal cords from the cough. So I'm still waiting for a referral for that. What I'd say with the healthcare is very hit and miss. Some of us are getting good healthcare and some aren't.
Yeah, thanks, Tim. Emily, just very briefly, have your symptoms improved over time, and what support have you had from your GP?
It's quite difficult to say whether they've got better or not, because I tend to have a cycle of different symptoms. So one thing gets worse and something else gets slightly better, and then something gets worse again. I've really struggled with my GP. I had to basically beg them for about 6 months to give me a blood test, even because I was so unwell. They did that, found abnormalities. I've had a couple of referrals, which I just haven't really had much out of, because, you know, I tell them my symptoms. And a lot of the time, because people don't know what to do, there's not enough research into it or funding for it, that I get told, you know, it might be anxiety, so please go home and sort yourself out. And I just don't get any investigations or help, really. The most helpful thing has been the long COVID clinic. I've not actually seen anyone in person, but I've had phone calls with them, and they've been able to help with an online fatigue clinic I did for 4 weeks, which helped my fatigue a little bit. But it has been quite difficult to get help.
Okay, thanks, Emily. And if I can come back to you, Stephen, could you just tell us, and briefly, because I'm going to move on to colleagues and their questions in a minute, you said about relapses and you'd had 3 relapses. Have your symptoms improved over time in other ways? And what support do you get from your GP?
It's real. I think, like Emily said, it's really difficult to know whether your symptoms have improved, because you do so many, you cut out so many aspects of your life so that you don't feel ill. And it's only when you have a relapse, and I actually thought, one day in October, I'm just as bad now as I was in December on Christmas Day. So I know they've not got any better. My experience with the GPs was that my surgery kept quoting 12 weeks at the beginning. We'll not see you or do anything until 12 weeks are up, and then we might be able to send you to a long COVID clinic. Or reality, though, is hardly anyone knew about the referral process. So this is sort of February time this year. You could talk to different people at the surgery and get different answers. It didn't even know which town they were based in. I didn't actually get to see a doctor until 6 months after contracting COVID. I had blood tests and I had a chest x-ray. But when I finally got to see a doctor, it's because my wife begged her doctor. She was seeing a doctor and she begged to see me. So I got to see one, and straight away she put me on blood pressure tablets because my blood pressure had gone up. And that's the first time anyone had taken the blood pressure. She put me on medication for depression and anxiety. They organised CT scans for my head because of the memory issues and concentration issues. A CT scan for my chest as well. Fortunately, they've all come back okay. But all I've got at the moment to sort of hang on to, and I say that, and that sounds like a strange thing to say, but sometimes you find that people don't actually believe you if you say you've got long COVID. So the only things I've got to hang on to are the fact that my blood pressure's gone up, my oxygen levels have been permanently lower than they should be since December, and the amount of ferritin in my blood has gone up. So it's like off the higher end of the scale now. So there are things wrong with me. It's just getting them diagnosed.
Yeah, we'll come on to that, but that's a very helpful opening picture. I'll call on Caroline now. Caroline Lucas has a question.
Thank you very much, Barbara. And just wanted to say how hard it is listening to all of the experiences you've all been describing, and just want to say how sorry I am and how tough it sounds. I was going to come to Emily first, not least because I saw you in Brighton, and I was just going to say that I don't know if you are a constituent, but if you are, do please get in touch. But I wanted to ask you first of all whether or not you could tell us how has your long COVID really impacted you financially?
So with being down here as a student, I have to pay rent. I was working through my gap year and until January of my first year of university. COVID hit in March, and I was actively job seeking then, but because I didn't have a job, I didn't get any furlough or anything like that. So I've really been relying on those savings. My parents help and contribute towards rent a little bit, but obviously it's quite expensive. They've got their own expenses, so they can't entirely cover it. I get the minimal amount of maintenance loan, which doesn't even cover rent down here for a year. And because the DSA don't recognise long COVID as a long-term disability, I'm unable to get any funding or any help from them.
Thank you. That sounds incredibly hard, and I'm sure there'll be something we'll want to pick up from that as we go forward. Tim, could I ask the same question of you, please?
Yeah, I've lost my job on the 9th of November, which has obviously had massive impact. Like I said, I've had to move out of the place where I was living, and I'm now living with my brother, which part of the time I'm having to sleep on the floor, which isn't helping my condition or anything else. I am one of the lucky ones. I've managed to get PIP, but I get £94.80 a month. So that is my sole income at the moment. I'm 37, I've got debts, I haven't got any health. At the minute, I'm being told by my previous employer's occupational health that I'm not fit to be at work. So if I'm not fit to be at work, what do I do for money? So I'm massively relying on my family, for everything, money, everything.
Thank you. That sounds incredibly hard. Thank you. And finally to Stephen.
Compared to a lot of people, I've been fortunate in that my employer's policy allowed for 6 months on full pay. and 6 months on half pay. So while I've been on half pay, we've just had to dip into savings and eat away at those basically to pay bills and everything else. I will not be on anything from the 3rd of December. So I've had a letter from my employer and they've suggested I might be able to claim some sort of national insurance based benefit. I've looked into it, but because of how I am, I can't really focus and concentrate, and it's a bit of a minefield trying to find out information on benefits. I did make a PIP claim in August. I sent the paperwork in, and I had a telephone assessment 2 weeks ago, and it'll be up to another 6 weeks before I hear anything about that.
Okay.
I'm in a strange position in that although I'll not be paid from the 3rd of December, I am still employed. So I can't claim any sort of unemployment benefits or anything like that.
Yeah, that's a good point.
Yeah, so
Okay.
it's unlikely I'll return to work, but I'm waiting on occupational health assessments and everything to decide exactly how I leave work.
Okay, thanks, Stephen. Okay, back to you, Barbara.
Thanks. And I think Paul's got questions to carry on with that financial theme. Paul.
Yes, good morning to all three of you, and thank you for coming to share your terrible experiences. You've partially answered this question already, I think, which is about whether you've been able to access financial support. But also, could you tell us what have been the biggest barriers for you in terms of accessing financial support? Stephen, would you like to go first?
Yes, my wife talked throughout it. I've probably been more positive than my wife has. I've said things like, I'll be back at work next month, and she's sort of poo-pooed it several times and said, you won't be. So when she suggested that we claim PIP, I wasn't really interested, for want of a better word. But she said, do you mind if I apply? So she sent off the forms and everything, and I just looked at them and I thought, I can't deal with this. I think I'll be back at work before. I know they're notoriously long in dealing with these claims, but I can't physically or mentally deal with completing the form at the moment. And it comes with guidelines, and the guidelines normally would be quite good, but I'm just not in the right place. And the wife who works as a support worker for people that have suffered domestic abuse, she is more used to filling PIP forms in with her clients, but even she struggled with it because at that stage I've not seen a doctor. We've got nothing apart from notes saying I'm not fit to work. So very little evidence that you can put on a PIP claim at that stage. And in the end, we ended up going to Derbyshire Unemployed Workers Centre to get some help just filling the form in. So that's probably the biggest obstacle, is just how overwhelming the benefits system is when you feel like that. And I think Emily summed it up. I get lightheaded all the time. That's probably one of my main symptoms, but I find it really difficult to describe. And Emily said it's like being drunk, and it is. You just cannot focus and concentrate. So yeah, filling paperwork in has been difficult.
Have you had any other advice about where you might get financial support?
No.
Okay, thank you. Emily, would you like to go next?
Yeah, so I think it is as well, as Stephen said, about having the recognition there from doctors and other medical professionals. So I've tried to apply for the disabled students allowance. I gave evidence initially from a therapist that I was seeing through my university, who I'd talked to her about my symptoms, and she'd supported me through the last year of university. and they did not take that. So I then got the long COVID clinic to write a letter, and they sent it off. I sent it off as evidence, and again they sent a letter back saying, we don't recognise long COVID as a long-term disability, so you're going to need more evidence. But when a lot of doctors won't, there's not enough research to be able to give you any solid evidence or advice on it. So you don't really have any more proof when you are trying to apply for these things.
And the long COVID clinic couldn't give you any other advice about how you could get financial support?
No, not as a student, no.
Right, okay. And Tim?
I would say, with regards to healthcare not giving us almost like a label, has a massive effect on trying to claim any form of benefit. Without that label, we're never going to get anything that we need. Not knowing what is out there support wise, you have to search for everything. As already said, fatigue, dizzy spells that you get, it doesn't help. All the forms that you fill out are exactly the same. So I've done the PIP form. I'm going through universal credit and a capability to work questionnaire for that at the moment. They are both the same form. Why do I keep having to fill out the same thing over and over and over and over again? Also, gaslighting sometimes from some people has a massive effect on the outcome of a different support. I was really lucky because I'm a military veteran, so I spoke to the British Legion back in January, and they offered some great advice. So thankful to them for that. But also because we can look relatively okay, but underneath we're not. And to quote somebody, appearances are very often deceptive, and that's what I live by now, because 1 minute I look okay, but I know I'm not.
So all three of you seem to have been cast adrift by the state, which won't recognise your illness as long term and won't give you any advice on how you can support yourself. That sounds pretty scandalous to me. Back to you, Chair.
Thank you, Paul. Thanks very much. And can I come to Sal now?
Yes, thank you very much, everyone, for everything you've shared with us so far. And I'm going to move us away from financial support now. At least one of you, I think it was Stephen, referred to talking to other people with long COVID. So we're interested to find out if you're part of long COVID support groups, and if so, is your situation similar to others? And do you have any idea of how many people there are, how many groups? Can I start with Tim this time, please?
Yeah, I am part of some groups online that have been brilliant. I won't name which platforms or which particular groups. A similar situation to myself, yes, there's a lot of people that are in a similar situation to myself. However, some of the figures, I believe that in June 2021, the TUC did a survey, and it's estimated that 47% of people with COVID have not been able to return to work, which shows that's 1 in 20, 5% have been forced out of employment in one way or another to do with COVID and long COVID. This was a further study was conducted in September 2021 by one of the support groups, which is the Long COVID Support Employment Group, which was showing a 1 in 13, that's 8%, have been forced out of employment. And this study had fewer participants than the one that the TUC did.
Thank you. That's very helpful. Emily.
I have been on multiple platforms, a member of a lot of support groups. I'm also in a Facebook group chat of young people who have long COVID. A lot of them are in a similar position. Some of them have had to drop out of their education because they just can't fund it, and health-wise they can't cope with it. Luckily, I've been able to continue with a number of my classes online, but that was a real struggle in itself, trying to get my university to allow me to do that. I think the last ONS report found that there was over 420,000 people who have been living with long COVID for over a year now. So there are vast numbers. Personally, while I have found comfort and support in the support groups, there are sadly a lot of deaths to do with long COVID at the moment, whether that's health related or mental health related. So personally, I've found that quite difficult to have to witness that. So I've taken a step back from a lot of these support groups.
Thank you. Can I just ask, Emily, do you know if these numbers are being tallied anywhere, the death numbers? I mean, I'm sorry to ask you, but we need to understand, particularly if it's cardiac deaths or respiratory deaths from long COVID. Has anybody said if anyone is collecting that data? I mean, if not, we will ask others, but I just wondered if you, as people living with long COVID, were aware of that.
As far as I'm aware, there's no official, bookkeeping of the number of long COVID related deaths, as far as I'm aware.
Okay. Well, thank you very much. I'm very aware time is moving on, but I'm very grateful for your answers. Chair, over to you. I'm really sorry, I didn't ask Stephen. My apologies.
Yes,
I do apologise. And I'm very sorry, you're on mute.
Sorry. No, I've not followed any or joined any groups. I do follow a long COVID group on Twitter, and I follow one or two individuals as well. But I've not reached out. Part of the reason is it's about saving energy sometimes, and I don't want to get involved in discussions about it. But I read it. I find it a useful source of information to find out how people have got on with medical issues, how long it's taken people to be diagnosed, what their experiences of PIP and their experiences of employment are. So it's quite useful. And sometimes it's a horrible thing to say. I'd rather we not be in this position, but sometimes it's comforting in a way not to know you're not on your own. I mentioned earlier where, I'm sure as time's gone on, people are less likely to believe in long COVID. I remember talking to people, delivering stuff to the house about long COVID, and in sort of March, April, May time, and they asked questions about it, they wanted to know about it, whereas now I think it's off people's radar a little bit and it's become the norm. So no, and I suppose the other reason I don't get any people involved is because it's pretty depressing as well. If you, like me, you do very little during the day, and I get bored a lot during the day. You don't necessarily want to read about other people's woes.
Thank you very much indeed. Sorry, back to you, Barbara.
Thanks, Val. And Susan has our final question in this group of questions.
What is your key ask, recommendation to the UK government? What would you like them to do? We would like to help you. So first of all, could I have Emily?
I think we need more funding for biomedical research, so that we can really find the causes of what is actually causing long COVID beyond the initial COVID infection. I think it would be important to recognise long COVID officially as a long-term disability. And on a more personal note, masks in classes and not just in the common areas, as has been, suggested this week. We need to protect young people. Students shouldn't have to be, choosing between their education or risking their health.
Thank you. And Tim?
Pretty much the same as Emily, really. Medical investigations without the gaslighting, more research and treatment. However, because we're not going to get the answers quickly, we do need that recognition of being a disability or a occupational illness.
Do you think the government is doing enough?
No. Honest answer, no.
And could I have Stephen, please?
I don't think I can add to what other people have said already. Agree 100% with what Tim and Emily have said.
But do you think it should be recognised more quickly?
Absolutely. I think it's got to be recognised as a disability to allow people to move on in terms of claiming benefits. And people generally don't like being labelled, but I think we perhaps do need to be labelled, and it would help us if we were. But no, this far. I mean, I don't know what sort of money is spent on research, but you look at the scale of the problem, and it's only going to get worse with different variants, and we could end up as a country with millions of people affected like this, and it's just not sustainable.
There's been a lot of research on vaccines, but perhaps not enough on after effects.
Yeah.
So thank you very much indeed, and back to the chair.
Thank you, Susan. We have a few minutes, and we've covered all of the ground we wanted to cover. But I just wonder, can we use those last few minutes to say, is there anything else each of you wants to add? Because I think you've been through with us, some really challenging and difficult times that you've been experiencing. So, is there anything else that you want to add, that you'd like to see, or that our group has looked at this on a number of occasions? So, if I start with you, Emily.
I think, as Tim says, I think it would be helpful if we kind of try and tackle almost the stigma around long COVID. A lot of people don't talk about it. I mean, publicly, Nick Knowles has said this week he's been suffering long COVID, and he didn't want to say that as someone in the public eye in case it lost him work opportunities. And, there is a lot of medical gaslighting. So, for example, I finally got through to see a neurologist, and I haven't had any further testing based on the fact that she said I was there. I'd gotten myself to my appointment and I was dressed properly. So that qualified me as, not being unwell enough for further testing. So I think that is something that we really need to tackle.
Thank you. I think Elora wanted to come in, didn't you? Sorry, I've just noticed that you wanted to come in with a question. As we've got a few minutes, do you want to do that?
Yes, thank you so much. And actually, Emily's just answered the question that I wanted to ask, which was about stigmatisation and about attitudes both within the professions, particularly healthcare professionals, and also attitudes out there in society, and whether you felt that has made it harder for you to cope with day-to-day living, as well as obviously putting blocks in the way to financial support. And I guess, Emily, you spoke about stigmatisation, and thank you for that entree to that. Shall I go to Stephen next and see if there's anything he wants to add to that, and then possibly come back to you at the end? Thank you.
Yes, it is making life more difficult. if you feel that people don't believe you. I've not had, fortunately, personal experience. I've not had a lot of personal experience of people in medical professions not believing me, because I do believe, although the GP surgery wouldn't see me for, or consider me to have long COVID until I'd had it for 12 weeks, at the same time they were fighting on the front line as well with the pandemic. So I can see where they're coming from there. It's just, I think, to be quite honest, since everything relaxed in the summer and people aren't wearing masks and they're not socially distancing, I think subconsciously people have stopped really listening to stories about COVID.
Yeah. Does Tim have anything he wants to add to that?
No, I can only agree and echo what both Stephen and Emily have said on that, really.
Right. And Emily, just last word to you.
I think maybe it might even be helpful having more government messaging, including long COVID, rather than just the initial infection. I know that COVID impacts all age groups, but I know particularly at a university age group, a lot of people, they're not wearing masks. They are reluctant to get the vaccination because they think that they're young. You know, if you get COVID, you'll recover from it. And it's just not as black and white as that. It's not, you know, you live where you die. There's so many of us in that grey area.
Thank you very much indeed. Thank you.
Well, let me echo those thanks from Elora, and thanks to all three of you, Emily, Stephen and Tim. We are grateful to you. I mean, I think we should just say what I think we've all said. We understand it must be very difficult to talk about some aspects of this, but you've really given us some food for thought this morning. We've looked at this a couple of times before, but it's really very helpful to hear from people like yourselves and just how difficult and challenging it is. So thank you. So I'm going to move on in a moment to our next session, but you are, Stephen, Emily and Tim, very welcome to stay for the rest of the session, but don't feel you have to. You know, it's there might be, you might have reasons for not wanting to. So let me open the second session now. In this session, we're going to hear evidence from experts and organisations working with those who are living with long COVID, so people like Stephen, Emily and Tim. And let me welcome first Jason Tetley and Kate Bradley, who are from Greater Manchester Law Centre. The Greater Manchester Law Centre is working with many living with long COVID who struggle to work as a result, and we've just heard some evidence of that. And they've conducted research, long COVID and work, surveying people who have long COVID, outlining key recommendations. Kate is the campaigns officer. And then we've got Ewan MacDonald, who's chair of the Society for Occupational Medicine. Ewan is a fellow of the Royal College of Physicians of Glasgow, Edinburgh and London, and fellow and past president of the UK Faculty of Occupational Medicine. And he is founder and past president of the Occupational Medicine section of the Union of European Medical Specialists and chair of the Society for Occupational Medicine Long COVID Multidisciplinary Group. And finally, on this panel, Sue Coe from the TUC. Sue is the TUC's Senior Equality Policy Officer. Now, the TUC has called for long COVID to be urgently recognised as a disability and COVID-19 as an occupational disease to give people access to legal protections and compensation. So you're very welcome. And let me ask you the first question. So Kate, Ewan and Sue, and Jason, of course, what is the current understanding of long COVID in both the medical profession and in the workplace?
For the first few questions, I'd like to hand over to Jason, who's the director of GMLC, because he's got a kind of overview, and then come back to the research a little later. Is that all right?
Okay, that's great. The first caveat I'd always put in is that I'm not a medical expert by any stretch of the imagination. In essence, our experience is very much gained from the people that have come through our advice clinic and from individuals that have been directly affected by long COVID itself. So they're people such as Emily, Stephen and Tim themselves. What in fact I would say is that the best description to me is confused. That's the most obvious word and descriptor that I'd use in terms of what the understanding is. We provide advice to litigants, potential litigants, and to employees and not to employers. But actually, the reflections that we've got back from those individuals that we've been in contact with is the nature of COVID in the way it's an emerging issue. That itself means that things aren't consistent. The nature of long COVID and the wideness of the definition in terms of some of the symptoms, and also the impacts that has on the individual, in that it's not, a lot of the time it's not consistent. And then there are times when people feel good, and then other times obviously when they feel really bad, and those symptoms can develop and wax and wane. But the other element around that, therefore, is we've got employees who are finding it very difficult and don't actually know what their rights are. And on the other side, we have employers whose knowledge is at best. I'd welcome the ACAS guidance itself, but yet again, we're going back down to semi-legal solutions to some of this stuff. And what in fact we're then talking about is reasonable adjustments and working at home arrangements. And what we do know is that there are thousands of people already within the employment tribunal system where the issues around flexible working, the requirements of the employee and the offer from the employer are very, very a wide apart in terms of it, really. So I'd say it's a very mixed bag. And one of the other things I'd just throw in there is there's also been a bit of a reticence, and it is an issue, where about 65% of the people that we've surveyed have actually said that they caught COVID at work or on the way to work. And that itself means that if you're looking to have a dialogue, a lot of employers themselves are defensive in terms of the circumstances by which individuals themselves have actually contracted long COVID. And that itself means that if you're looking at a partnership solution to this, you're starting immediately on a ground which is not necessarily common ground in terms of the circumstances by which employers themselves have contracted it. So that's what I would say. It's a very confused position. Knowledge is patchy and haphazard at best.
Thanks. And can I come to you, Sue, next? Sue from the TUC.
Thank you very much. And can I just start off by saying that I listened to the evidence in the earlier session, and I really applaud Stephen, Tim and Emily, and the impact and the clarity of their evidence, because it very much spoke to what we have found in our work. And at the TUC, our focus is the workplace, and sort of building on concerns that were expressed by our member unions and by members of our Disabled Workers Committee. We undertook quite a considerable evidence gathering exercise, taking evidence from over 3,000 workers with self-reported long COVID. And what they told us showed that employers' understanding of long COVID is very, very limited. And there is a very high level of negative experiences of workers with long COVID. So, for example, over half of told us that they had experienced some form of discrimination or disadvantage as a result of their long COVID. And echoing what people told us earlier, there is a really high level of lack of belief. So, around 1 in 5 workers said that their employers had expressed disbelief either at the impact of their symptoms or some that even that they had long COVID at all. So it seems that there is a significant way to go in building understanding of employers in terms of supporting workers effectively with long COVID. But also, as has been highlighted a number of times before, we need government action on this. I mean, we can see from the speakers at the previous evidence session, there is a real need now for government to take action and specify that long COVID is a disability, because the protection is needed now for workers.
Thank you. Yes, thanks, Sue. Thanks. And let me come to you. And because the question was, what's the current understanding of long COVID in the medical profession? Can you help us with that? You're muted, Ewan.
Thank you for that big ask and a big ask question. Can I just correct something? I'm not the chair of the Society of Occupational Medicine. I'm the chair of the long COVID multidisciplinary group of the society. And the other thing is, I've been involved in drafting the guidance that the Society of Occupational Medicine has provided for workers, for managers, and return to work for health professionals as well. And these are in the public domain, these documents. So in the current understanding, well, it's variable, I would say. I think that first of all, we're talking about a condition. Generally, it's agreed as symptoms lasting longer than 12 weeks. And the majority of people do get better in 4 weeks, but some will have symptoms which continue after that, and quite a large proportion. And it gradually tails off. The symptoms can tail off, but for some people, there's symptoms going on more than 12, 18 months. And they're significant. Most of these individuals are working, and so talking about the understanding of long COVID in medical profession, I can't talk for the medical profession in general. But what I could say is, from the perspective as an occupational medicine person who sees people in relation to work, and our role is to help people return to work and return to their jobs without harm to them. But in the early days with COVID, there was a lot of skepticism. I would say medical skepticism about the condition. You know, they said, sort of dismissing it really as a sort of, this is another version of chronic fatigue, and to that has coloured, I think, some of the early responses of some of my colleagues in primarily treatment medicine. The issues depend on where you sit. There still is a sort of dominance of biomedicine about COVID, the virus, and you get better from it. And in fact, there's quite a proportion of people have long COVID. And the latest ONS study suggests 1.2 million people in the UK have had long COVID. Now, if you work that out, it's almost 4% of the workforce. And most of these individuals have had difficulty in accessing support or advice because the NHS has been so highly pressurised with people who are more ill, and they're generally almost all ambulant individuals, and so they're not posing any emergency sort of situation or apparently seriously ill issue in terms of all the other burdens of the NHS at the moment. So I think, first of all, 1.2 million is the latest ONS figure. Now that is almost 4% of the workforce. Most of these people are actually of working age. Most people with COVID, long COVID as we call it, are of working age. And so we've got another tranche of individuals who are, many of whom are having difficulty getting back to work. So I'm talking about the medical profession, difficult to get back to work. So general practitioners are at the front line as usual in this, with the 7 or 10 minutes they may have to deal with somebody. And if they see somebody with long COVID symptoms, they're limited in the resources available to general practitioners and for long COVID their long COVID patients. And quite a lot of the long COVID population now are not actually actively attending medical profession. They're not actively attending, they're just having to tolerate it there. So there's understanding of it, there's recognition of it, but there's been, but in both the medical profession and among employers, it has been difficult. Because why is it difficult? Because coronavirus, COVID-19 is a new disease. It's a new virus. It has a very broad target. It can hit most target organs in the body. And so therefore, when it first presented, both clinically and in the workplace, people didn't understand it. And if you don't understand it, you don't really think it's there. And so, but that there's more recognition now. So for doctors in the health service, I think there's more recognition now. But I would say that's only the health service is only now starting to get itself focused on this group of patients who are not acutely ill, they're not requiring hospital attention, and most of their health problems are stable. So and what is happening across these islands is, because I chair, because I'm in the Department of Health in England has put a lot of resources into it, has a task force in which I sit, even though I'm based in Scotland, and they are setting up about 100 one-stop shop clinics. Because the problem with people with long COVID, they may have fatigue, they'll have breathlessness, they have a loss of taste and smell, they may have loss of taste and difficulty concentrating, the brain fog. And so basing treatment on the general practitioner, if he's dealing with a patient with several different symptoms, if they need further investigation, so if it's a respiratory problem, you get referred to the respiratory medicine clinic in the hospital. If it's a cardiac problem, you get referred to the cardiology place. If it's difficulty concentrating, well, that might be to a neurologist or a neuropsychologist. And so the long COVID person who needs further investigation is faced with this sort of revolving door of being sent to one place and sent to another place and sent to another place. Now, the real issue with long COVID is the requirement for rehabilitation, i.e. helping them to overcome and cope with their disability or their symptoms and help them to get back to maximum function, including work. And that's what.
Could I stop you there, Jon? Because I think we're getting into questions that my colleagues will want to ask, and I think your initial view of giving us the current understanding of long COVID in the medical profession has been very helpful. But my colleagues have got different questions, and I will just add, Kate Bradley has put into a figure into this chat that 1 in 5 sufferers being disbelieved broadly echoes the numbers in their survey too, and that she thinks your TUC survey is excellent. So let me come to Simon, who's got a question.
Yes, thank you very much. I think, as Ewan has just made clear, it is a complicated and evolving situation, and some of the medical profession seem to be as unclear as lay people. So if I could start off by asking Sue. So if you look at the experience over the years of how organizations like the TUC and employers have come to recognize conditions which perhaps were not fully understood at the beginning, but have then evolved into being understood as a disability and treated as one. If you look at where we are with long COVID, are you optimistic or pessimistic that at the progress we are making in terms of trying to understand it sufficiently that we can actually start putting labels on it that we all have a degree of confidence in?
Well, the kind of definitions of disability in the Equality Act are clear, and there is really clear guidance that goes alongside that. And the guidance, sort of states what should be considered a disability, talks about 12 months, but also the likelihood of it lasting 12 months. It deals with the impact of multiple impairments on people in fluctuating conditions as well. So if you look at the results of our survey, if you look at the ONS data, which shows, I think, around a third of people are experiencing long COVID for more than 12 months, it is likely that many workers who have long COVID would be covered. However, the situation we're in at the moment is that we have more employment tribunal claims than we have for a decade. There is, I believe, earlier in the year, it was around a 14-month backlog for employment tribunal claims to be heard. And as we have heard earlier, what people need is support now. Workers are being discriminated against, workers are being forced out of work. And we need protection now, not established through employment tribunals a year down the line. And it's somewhat frustrating given that there is a possibility through secondary legislation of long COVID being named alongside other impairments that are automatically covered by the Equality Act. You know, it's a protection that is urgently needed and could be easily achieved, as colleagues were saying earlier, both in terms of protection from discrimination, but also in terms of supporting workers to access the reasonable adjustments that they need for their fluctuating condition.
Thank you, Sue. That's helpful. That very neatly leads us on to either Jason or Kate commenting on that, because I think if you look at what's going on in your own practice, what would be most helpful to try and create some sort of resolution and clarity in some of the cases you're dealing with? What could or should be done?
I think that the first thing for us is about access. It's about access to information and advice for people affected by long COVID. If you just take the figures, okay, 1.2 million people nationally would mean about 50,000 people in Greater Manchester affected by long COVID. There's an access to justice issue here, where generally if you're employed, you're unlikely to get legal aid. So immediately, therefore, in terms of your ability to enforce your rights is limited. There are 3 free-to-access employment advisors in Greater Manchester for 2.8 million people. Think about that. So there's 50,000 potential cases and 3 employment advisors to try and assist in terms of pursuing cases that you may well be able to. So therefore, what we're reliant on is people having the skills and the aptitude to negotiate with their employers, to enforce their rights, which at best are scant at the moment and are emerging all of the time. But, you know, so the disability legislation itself, in terms of the protections, is far from clear. So you're not going to get sort of no win, no fee lawyers taking this on, because the law is still emerging. So what in fact we're then relying on is people negotiating their own with their own employers at a very time, as we heard earlier on, at a time when they themselves are ill and don't necessarily have the capacity in order to do it. So those are the issues that we face. And then the other underlying element of that is also the financial pressure that you've seen, and you've heard from all three people earlier on that mentioned the lack of accessibility to financial support. And what in fact we are likely to see is lots of people with long COVID themselves starting for the very first time to be involved in the obstacle course, which is our benefit system, particularly around disability benefits. So I think there's a perfect storm there in terms of it. What I'd be likely to see is a clearer definition in terms of disability that clarifies the situation to enable those individuals to have the capacity to be able to negotiate, but they're on firm ground. But also, if necessary as well, it also provides clinics and employment advisors and advice services such as ourselves to have clarity so that we can go out and actually ensure that people are aware of their rights. And I do believe as well that it would also give ACAS and some of the other sort of structures that we've got in place in terms of regulating the relationship between employers and employees far greater clarity in terms of the ability then to be able to ensure that employers know exactly what their obligations are and employees obviously know exactly what their rights are so that they can enforce them.
And thank you very much. Just for when you answer the next question, could you just make sure there's something funny with your way your voice is coming across? So I don't know whether it's your speaker, you're coming or going a bit, but just if you could try and fix that before we speak again. Ewan,
sure.
very briefly, Ewan, you've been very clear on the complexities behind trying to come to a diagnosis. But if you look at it from the other end of the problem, which is given the problems that are being described so accurately and the fact that they are happening in very large numbers in real time, what can or should you think occupational medicine practitioners and the medical profession do to try and bring greater clarity so we can get rid of some of the sort of insecurity and the grey areas which currently are there? And if you could just do that very briefly, I'd be most grateful.
Okay, well, medicine in general, there's a lot of research going on at the moment. Look at a lot of big studies, multi-center studies, following people with COVID, and some of these studies are looking at the interaction with work. So that is going to improve knowledge. You asked the question about knowledge. In terms of occupational medicine, first of all, only 50% at most of the UK workforce have access to occupational health, which means 50% of employers and employees don't have access to occupational health. And that's because there's no universal coverage of occupational health, because occupational health is not provided by the NHS, apart from till the NHS do its own workers. So that's a big issue, and there's a separate campaign going on about that. So not in the occupational health world, what is happening is I and my colleagues see people in our clinics who are turning up because they've been referred by their employer usually, or they've asked to be seen, self-referral, and they've had from our perspective, they've got multiple morbidity, i.e. they've got a number of things that are bothering them, that are affecting their functioning. They may not have been properly evaluated, and they often always talk about a difficulty in accessing support, and this is because they have multiple things, they may have multiple issues that are affecting them. And so in the occupational health world, for example, one of the big occupational health services has had to set up rehabilitation clinics for an employer and actually try and provide rehabilitation in that context if the employer has the funding to do that. But that's rare. That's unusual. These are the blue chip companies. And so for most people, they're not getting that kind of support. The issue then is the interaction with the employer, and that's the issue. We've produced guides for managers, but managers need support as well. And if you're a manager of a say small organization and you only have one case of long COVID, you don't have any experience. And often they don't know where to access experience. And really it reflects the TUC report. So does that answer your?
Yeah, Ewan, thank you very much. That's really clear. Barbara, back to you.
Thank you. Thanks. And could I come to Paul next?
Yeah, good afternoon to all of you. We've heard in both the sessions about all the difficulties that people suffering from long COVID have in getting the financial support and the other support that they need. But could you try and identify for me what is the greatest barrier that's preventing sufferers from getting the financial and other support that they need? I'm aware that Kate hasn't had a bite of the cherry yet. Is that one that you could take on?
If we're working through the questions, we've kind of split the balance of them. So I was going to pass that over to Jason as well, but I could also come in on it. I'm sure that Jason will mention access to justice as a key element about getting the advice even that you need to access the financial support. So if you're a person who has never before encountered the benefit system, and especially if you've been in work for your whole adult life, you don't have a recurring disability that's meant that you were out of work for any other stage, then actually having access to a benefits advisor to tell you what of the myriad benefits you're entitled to. The fact that universal credit is so low now and often not livable for someone who can't also be in work, from which a vast majority of our survey participants said they couldn't complete a single day of work at the stage they were at of their long COVID when they replied to our survey. So if you're in that situation, then the greatest barrier is going, well, how do I even get support? And I think one thing to mention is that about half of our participants in our survey, which was small but had similar outcomes to the TUC survey, which was much bigger, around half of them said they were suffering with anxiety and depression. That is listed as a symptom of long COVID on the NHS website, but I'm not sure whether it's a symptom of long COVID or a symptom of having to live with long COVID while facing these barriers and lack of support that you're living with. Perhaps it's both, that's not clear. But either way, trying in that mindset to handle the complexities of the benefit system without access to advisors and advice, as so much of that has been cut, can be deeply demoralizing for people who've never had to encounter it before, and even for people who have, because it changes all the time and it changes in ways that are quite hard to deal with in terms of, you've got so many different types of benefit that you need to go for. And as I said, universal credit is quite low to live on if you're suffering with a disability. So that's my suggestion. Did you want to add anything to that, Jason, just because I stole your question?
It may be that the anxiety and depression is coming from the way that they're just being ignored by the system. And at a time when they actually need help and need to find their way through the system, they're not physically in a position to do it.
Definitely, it definitely came out in our survey that was the thing that people were saying qualitatively. A lot of our questions are qualitative, and the thing that kept coming through was frustration and anxiety, not just with the symptoms, although it is a very anxious thing to have those symptoms, but with the way they were being treated by the wider systems as well, and the lack of support they were facing.
Or not being treated, more like it. Sue?
In terms of the barriers for those living with long COVID in the workplace, I mean, what we found was that there were general issues which reflect the experience of disabled workers more widely in the workplace in terms of disbelief and discrimination. But specifically, what we saw was a complete mismatch between the types of support and types of adjustment the disabled workers who had long COVID were asking for and those that they received. And in particular, it was the flexibility to support fluctuations in their symptoms. And here there was the largest mismatch between what workers with long COVID had asked for and what the employer had provided. And this lack of flexibility, both in terms of rejections of flexible working, including flexible hours and home working, but also a lack of flexibility in phased returns of work to work, which meant that we had many reports of phased returns breaking down because there wasn't that flexibility built in, because there wasn't the understanding of the impact that fluctuating symptoms had on these workers.
Thank you, thank you. And Ewan, I should say we're running quite short of time. If you've got any brief comment you want to add to that, please do.
Just to add balance to this, why I support everything Sue has said. In England, they've set up, I don't know if it's already been discussed, 100 one-stop shop clinics right throughout England for long COVID. So support is being developed by the NHS, multidisciplinary clinics. And these are also, they're all focused on helping people improve function and also will link to occupational health where it exists. In Wales, in Scotland, the services are being, the new additional services are being based around the general practitioner to orchestrate, which I don't personally think is ideal. And in Wales, similarly around at the GP level. I think GPs are grossly overloaded at the moment. So, but there are services developing across the UK and in Northern Ireland. they're developing a long COVID clinic. So this NHS is getting its act together, and how effective it will be is another matter. But there is support.
We will see. We will see. Thank you very much. Back to you, Chair.
Thank you. And can I come to Elora next?
Thank you very much, Chair. I think I should declare an interest because I co-chair as a Vice Chair the Bevan Commission, and Ewan is a commissioner on that and has been involved in looking at setting up a registry for long COVID across Wales. So I think it's inappropriate for me to ask Ewan a question, and he's probably in large part answered this anyway, because I wanted to ask how well businesses are set up to deal with the potential for long-term sickness such as long COVID. And Kate's already commented on the difficulty over benefits and so on. I wonder if I could go to Sue first and how she sees that from her perspective.
In terms of how well UK businesses are set up, we don't feel that they are set up currently very well to deal with what, as Ewan has highlighted, it's a substantial issue and it's a growing issue. And we have seen very little from the government on long COVID as a workplace issue, and it's been left to the likes of the Society for Occupational Medicine to step in and produce their really good guidance on this. But you know what we see, as I was saying, we see rigid phased returns, we see simple adjustments like flexible working being withheld, and we see absence management policies being used punitively, leaving workers fearing for their jobs. So I think, you know, we know that this is a significant issue. We know it is a growing issue, and it feels that it needs to be given more prominence at a government level.
Right, Kate and Jason, I'm not sure which of you want to take this one.
I'll make this really, really succinct if I can do. One, in fact, I'd say is just picking on Sue's issues. I think we can look at this through the prism of long COVID, but we can also look at it more wider about the way that employers deal with individuals suffering long-term disabilities and long-term illness. And my issue around that is not very well at all. And that's about what does flexible working mean? You know, what's the impact upon the individuals and their long-term employment prospects? So I think that not only is the specific work in terms of long COVID here, but some wider elements around ensuring that employers are fully aware not only of their responsibilities, which is one element, but the practical application of those. And I am going to go back to, you know, the trench warfare of employment tribunals is a lot of the time is dealing with the specifics in terms of what the employer believes is a reasonable adjustment and what the employee themselves wants. And generally what happens is two things: either the employee leaves or they lose their job. And I think the big thing in terms of urgency here is people are losing their jobs now as a result of long COVID because those adjustments aren't being made.
Jason, can I just ask you, if from the legal point of view, do you think there is a need to differentiate between long COVID and people where they have been key workers and acquired their COVID as part of their job versus the rest of the population? Because we got a lot of people in the NHS who were going in throughout the pandemic, often before testing happened. So I just wonder what your or Kate's comments are on those.
What in fact I'd say is I think that rights themselves should be universal in terms of all employees generally. And the other thing I would say is we can pick out key workers, but our experience has been the very first person we advised was a supermarket worker who'd worked additional shifts at the early stages of the pandemic and undoubtedly received, this is in the first lockdown, who contracted long COVID at work. So I think that it's a dangerous route to try and differentiate one worker from the next, because the circumstances that the individuals themselves face and how they got COVID, ultimately this is about the way that we deal with it as opposed to the circumstances in terms of how it's contracted.
Thank you very much, Chair. Can I hand back to you? Thank you.
Thank you, Laura. And let me come to Susan now.
Are there clear enough guidelines for employers? And if not, what are the key messages that should be included? And I would like to say, I think for small businesses, it is really very difficult coping with long COVID. Now, who will answer this first? Maybe Ewan.
All right, thank you for that. Yes, I agree with you. It is very difficult for employers, and it's difficult with long COVID, but it's also difficult for other workers who have a number of multiple health problems as they age. So there is guidance. There's the SOM has produced, return to work guidelines for health professionals, return to work guidelines for recovering workers, and we've also produced a return to work guideline for managers. In fact, the EU, OSHA, the EU, contracted with me I led the production of these guidelines, and have contracted with us and have issued, with the consent of the SOM, the EU has issued the guidelines that the UK Society of Occupational Medicine has introduced. So healthcare doesn't have political boundaries. So there are guidelines, and for managers, for example, the key thing with any sick employee is keep in touch with them, so that persons are isolated. Think about the worker's return, have a return to work conversation, think about the modifications and adjustments that can be made. Most workers can be accommodated if there's flexibility and adjustments, providing a lot of support in the return to work, and keeping with that support, providing it regularly as well, not just assuming they're back. If you're ill and when you go back to work, everyone's very sympathetic. After a week, generally they're forgotten, and so it's maintaining that, because this is tends to be a long-term condition. I think it's important to have an expectation of recovery, because people do recover, and some people recover relatively quickly from COVID. Some people it's longer, and some get long COVID, but people with long COVID won't necessarily have it indefinitely, or else they'll have a slow recovery. They may have some residual loss of function, such as, say, if it's lung scarring, then they're going to be more, their exercise ability is going to be less. So they may have permanent disability, and quite a few will do, but that's a minority of those who get long COVID. So I think but what is needed actually is a service for the SMEs and micro enterprises. They've got enough business trying to survive and get the goods out the door. And they don't have access to much support. It's really important that TUC and the small business or network and government provide guidance, which is available, as showing you some, but provide guidance, make it much more widespread. Guidance for the worker, guidance for the healthcare professionals, guidance for return to work for managers, guidance for return to work for workers. And that actually exists. I've shown you some of it, but it needs to become, disseminated much more widely. And
what happens if they feel they're not fit enough to come back, or only part-time because of fatigue?
Well,
could I just say, like, we're down to our last few minutes actually now, Susan. So could we go to the other panel members on this question?
Yes. Could we have Sue, please?
Thank you very much. And just to say, building off Ewan's previous point, we are working on guidance for reps on long COVID that will support them in engaging with employers around this. In terms of clear guidelines for employers, we would like employers not to wait for government to specify that long COVID should automatically be considered as a disability, and to act as if it had already been specified by this. We would obviously support employers consulting with trade unions and disabled workers that have long COVID on what steps should be taken, because disabled people themselves know the solutions are that they need, and the reasonable adjustments are put in place, including flexible working, which I think is key to supporting many workers returning to work and remaining in work.
Thank you so much. And Jason.
I think I'm going to come out this one. Sorry. Yeah, I just wanted to echo everything that's been said. It does sound brilliant, but I would also want to stress that in order for guidelines to work, the basis of the guidance needs to be clear. One of the problems that we face when trying to put together guidance with our employment law service, and which ACAS faced, is the lack of clarity on the underpinning legal basis of people's ability to claim, for example, for disability discrimination, or in fact their rights in the workplace. The laws on which it's based need to be clear, what's required of employers needs to be clear, and how people can enforce their rights needs to be clear. Otherwise, employers aren't in the position to deliver the best practice, and employees aren't in the position to understand what they're requesting and what's, what the basis of their rights is. So that's the key for me would be whether it has to come in by statute or by case law. I think it's really important that we bring in some kind of definitions and some kind of roles for that in policy and guidance, and also that we have to be aware that case law takes a long time to filter through, and we don't have time on a problem that's affecting 1 million people. So I'd really strongly advise considering statute, considering adjustments to law on this that will enable people to understand the basis of their rights better before they get to court, which can take a long time.
Thank you so much. It's so important to get it right.
Thank you, Susan. Thank you. Well, we're down to our last couple of minutes. So the very last thing we want to ask, and it really is a sort of 30-second to 40-second answer we're seeking from you, is what is your key recommendation for government? Sue, I think you made it earlier in your opening piece, so perhaps you could tell us again.
Well, in addition to that, I think there has to be action on sick pay to ensure the workers can self-isolate, and also we need to listen to disabled workers. We need to destigmatise long COVID, and we need to raise its profile far more as an issue.
Okay, thank you, thanks. And Kate or Jason, whichever you want to take that.
Mine's really simple. I think it's the clarity of the law that's been mentioned before. The other side is that giving visibility to people, 1.2 million sufferers of long COVID. But the biggest shame, I think, is the fact that the strongest voice for people from long COVID is a Facebook group at the moment who've done amazing work in terms of raising the issues. But actually, there's 1.2 faceless people to a degree, and it's about bringing them out and making them at the centre of the debate as we go forward.
Okay, thank you, Jason. And Ewan,
I think we should remember, can we afford 4% of the workforce not to be able to work and fall out of work? That's the question for the country. And what is needed is very good advice and support to those who've got COVID, very good advice to employers, and improved health resources targeted at this group, and I think that was just. It's really very the size of the problem. We shouldn't underestimate it. It is going to have a major hit on the economy of the country, as well as we need to provide better health services to help reduce the risk to individuals of long-term unemployment. Very
much so. Thank you. Well, I think it's been so useful in this session to hear first from Stephen, Tim and Emily, and I really thank them again for joining us. And thanks to our people from organisations working with people with long COVID, Kate and Jason, Suko and Ewan McDonald. Thank you very much indeed. Thanks for those who watched at home, and I'll end our meeting there. Thank you.